Good afternoon and welcome to ICE Webinars, a cool place for hot topics. ICE Magazine is proud to bring our monthly webinar series to the imaging industry. ICE is the community that directly links nearly 7,000 imaging professionals with a monthly magazine, online community, annual conference, and now a monthly webinar series. The ICE Magazine team will be exhibiting at the 2021 AHRA conference in Nashville, Tennessee, August 1st through the 4th. On Monday, August 2nd, please join us for our Drinks on Ice event at Bar Lines at the Omni Nashville Hotel from 4 to 5:30 p.m. for networking and fun. You can stop by the ICE booth 331 on Monday during exhibit hall hours to get your drink tickets. Don't miss out on this fun event. ICE Webinars would like to thank our sponsor, KA Imaging. KA Imaging develops unique detectors and imaging products that leverage cutting-edge multi-energy and phase contrast X-ray technologies for medical, industrial, veterinary, non-destructive, and scientific imaging customers. Their mission is to enable their employees the freedom to innovate and create high-performance products for customers using cutting-edge advances in X-ray technology. For more information, please visit kaimaging.com. Today's webinar is eligible for one ARRT Category A continuing education credit by the AHRA and is approved for one CRA credit. You can obtain your continuing education certificate by completing the post-webinar survey. More details on this at the end of today's webinar. We're excited about today's presentation featuring Dr. Karim and Jay Potipcoe. Karim, you may begin whenever you are ready.
Thank you so much for that, Jennifer, and also we're very pleased to partner with ICE. Hi everyone, my name is Karim. I am the founder and Chief Technology Officer for KA Imaging. Today we're going to talk, today I'm joined here with Jay Potipcoe, who is an application specialist also at KA Imaging. We're going to talk about improving departmental results with single exposure dual energy subtraction X-ray. It's an exciting new modality, exciting new technology that has lots and lots of promise for improved clinical, operational, and financial outcomes at the hospital. Next slide. So the learning objectives for today's webinar are that at the end of this hour, we would like you to understand what dual energy subtraction X-ray is, what are the limitations of old dual energy subtraction techniques, and how a single exposure detector can overcome these limitations. We also want you to understand the clinical benefits that are enabled by dual energy for the early detection of small nodules, pneumonia, pneumothorax, and coronary calcium. We also will learn more about, and Jay is going to walk you through hospital implementations of single exposure dual energy X-ray and to understand the operational and economic benefits that come from using dual energy. Next slide. So the big problem that X-ray is really used for heavily is that lung disease. Lung disease is the third greatest killer worldwide. Pneumonia, lung cancer, pneumothorax, tuberculosis, pneumoconiosis, all of this fall into the same category. It's responsible single-handedly for more than 5 million deaths globally. Next slide. And as you can see, it doesn't spare anybody on any continent. Lung disease is an issue as much as it is in North America, as it is in Asia and Africa. Next slide. Now, compounding lung disease, of course, is our recent phenomena of COVID-19 pneumonia. It's been a big problem, of course, in North America, well known. It was responsible for a huge drop in imaging volumes. Mid-March 2020 is, of course, when COVID was first recognized as a problem. And you can see how inpatient, emergency, and outpatient volumes pretty much plummeted. American Hospital Association said that US hospitals lost $50 billion USD in April, mostly due to canceled elective procedures. And some US healthcare providers also filed for bankruptcy, and there's been quite a bit of consolidation. Next slide. The one kind of silver lining in all of this is actually X-ray. whereas volumes for pretty much every medical imaging modality, ultrasound, nuclear, MR, mammo, interventional, CT, they all dropped across the board. The one thing that did see an increase in volume was X-ray. And that was primarily X-ray being used in the emergency for walk-ins, and that was primarily portable X-ray. Portability, as we all learned over the course of COVID, is very, very important when it comes to imaging, because when you have an infectious patient, you don't want to spend a lot of time sitting there cleaning rooms, because that really affects workflow. Next slide. So WHO in June 2020 also recommended using chest X-ray imaging for COVID-19 patients in a number of scenarios. When the PCR test is giving you a negative, but the patient is clearly symptomatic, the PCR test is delayed or not available for a symptomatic patient, figuring out whether you should admit a patient into hospital who's got mild symptoms, determining if the patient should be in ICU or not, and actually figuring out if patients who are in ICU should continue to be in ICU, because it can also be used for longitudinal monitoring. Next slide. Which is what brings us to today, and we're talking about X-ray and different types of X-ray imaging and the innovation that dual energy has brought. So I think everyone is quite familiar with this slide. You've got X-ray that's used in a fixed room, and you can see on the left-hand side, the lady is holding a X-ray detector. You can also see the X-ray sources. On the right side, you see the mobile X-ray, and in this particular case, the detector is just hiding in its slot. But really, these are the two ways in which you see X-ray being deployed in departments in hospitals today. Next slide. Now, X-ray, as most of you probably know, is the biggest medical imaging modality. It's, of course, the original medical imaging modality. Röntgen discovered it back in 1895. Marie Curie was the one who actually socialized its use, especially in World War I, when she drove around a little truck and took X-rays of all the wounded. Even today, 2 billion procedures are carried out annually for X-ray. That beats hands down anything else that even, like there's nothing that even comes close to it. And 60% of all medical imaging uses X-ray. You can see chest is, of course, a big driver for X-ray, but so is spine and abdomen and extremities and others. Next slide. And here's a nice image showing Röntgen's first X-ray and today's X-ray. And while there are some differences, especially in sharpness, in 120 years, there hasn't been a huge amount of change in the information that X-ray provides. While I can still see, I can still see the bone just as clearly as I did back in the day, but the soft tissue is really hard to see. Next slide. So the main problem, of course, for X-ray, and this is a well-known problem, is that X-ray is limited on tissue differentiation. You can't tell the difference between soft tissue and bone because X-ray just creates shadows of the body, right? Now, there is a solution to this in X-ray. It's been around for a long time, dual energy X-ray, but unfortunately, it hasn't gained traction. And today we're going to learn why that's the case. Next slide. So what is dual energy? So when we talk about a traditional X-ray, and I promise I'm not going to show you a lot of equations, so don't worry. Traditionally, when you have X-ray, it's a polychromatic source. So the source contains, like when it shoots out a 120 kV beam, that's actually a spectrum, right? It's a broadband spectrum. You have lower energies in there as well. But really the X-ray detectors, the sensor plates, they just see that as, in a sense, an average energy. What dual energy physics does is it breaks up that X-ray spectrum and tries to separate different energies in that spectrum. So take, for example, this figure that you have in front of you. You've got an object that has soft tissue, and then you've got, on the left, an iodinated vessel or calcification. An X-ray of the same energy passing on the right through just the soft tissue versus one that goes through the soft tissue and the iodinated vessel will have very different absorption and very different characteristics. And that's primarily because soft tissue doesn't absorb a lot, whereas the iodinated vessel or calcification will absorb more. So their characteristics are different. Next slide. Now, what dual energy does is simply say, look, I recognize that X-rays of certain energies, like for example, if I look at a 60 keV monoenergetic X-ray, I see that there is a difference in the attenuation coefficient for soft tissue and bone and iodine, right? There is a clear difference. The blue curve at 60 versus the orange curve versus the yellow curve at 60 on the x-axis shows that there is a big difference in the attenuation. If I can get two energies, say 60 and say 120, now you can see that there is a difference between the attenuation in soft tissue at 60 versus soft tissue at 120, and the same for bone and the same for iodine. This difference is quite useful because it allows us to separate parts of the body that absorb bone more from those that the x-rays that are absorbed more in bone from the x-rays that are absorbed more in the soft tissue. And that's kind of the principle that underpins dual energy. It's a difference in attenuation for different energies that allows you to pull out different materials in the x-ray image. It's the physics. Next slide. And the way you pull it out is ridiculously simple. All you're doing is a subtraction. So you have image data at a low energy, you have image data at a high energy, and you do what's known as a weighted logarithmic subtraction of the low and the high image data, and you're able to pull apart materials of interest. I mean, there's more to it than that, but that's really how it goes. Next slide. So this is a nice figure. It gives an example of what dual energy produces. This patient has received X-rays. On the top left, you can see what a beam spectra looks like. And in this case, this person had a low energy, like a 60 kV X-ray, and then a higher energy, a 120 kV X-ray. And then the dual energy algorithm was used to subtract the images using the correct weighting to generate just a soft tissue image on the bottom left and a bone tissue image on the bottom right. So by taking two X-ray images, you have been able to generate 4 images from this. The soft and the hard tissue images are of course supplemental, but you can see how useful they may be for diagnosis, because now I'm only getting soft tissue and anything with bone or calcium has been removed. And on the flip side, I get only the calcium and bone, and anything with water or soft tissue has been removed. And that's really the benefit of dual energy. It works on the physics of X-ray absorption in the body. Next slide. Now, the benefits of dual energy X-ray are plentiful. You obviously get better patient outcomes because it's early disease detection. There's lots of literature that shows how effective dual energy is at picking up a variety of diseases: pneumonia, coronary calcium, lung cancer, lung nodules, pneumothorax, tuberculosis, the list can go on. You also have better safety for the patient and the operator. It's less radiation than a CT, and obviously the higher accuracy allows you to reduce diagnostic error and malpractice, especially in places like missed nodules. You also get higher operating efficiencies because now the images are so useful, because you get soft tissue, bone, and regular X-ray, that a variety of clinicians and departments, radiologists, internists, ICU residents, they can all make accurate diagnoses. Their ability to diagnose is improved. And lastly, of course, the adoption cost is much lower than a CT, right? So there are lots of savings here. And from a workflow perspective, it maintains an X-ray workflow, so you get the throughput advantage. Next slide. The big question then, of course, that remains for everybody is, well, if dual energy is so good, why is it not more popular? Next slide. And the answer to that comes from the threefold trifecta. You've got the issue of access, quality, and cost. From an access perspective, because dual energy typically uses 2 X-ray shots, you end up with higher radiation per scan. So there are very limited use cases that allow you to use more radiation. Secondly, it's not portable, and X-ray is pretty good in a static. It's the portable where the real benefit could be had. but dual energy solutions have not been portable to date. And because of the radiation and the lack of portability, and they also don't provide lateral images, it can't really substitute standard chest X-ray. So it's like a niche use modality. It's usually an option. On the quality side, because you're taking two images, patients like to breathe, their hearts beat, you end up getting something called a motion artifact. It's a misregistration error shown on the right-hand side. It looks like a bright white streak, usually because the heart has moved in the milliseconds required to take the second image. And that's an issue. That's been a standard issue for dual energy. And the last piece, of course, is cost. The dual energy solutions today are just available from very few manufacturers. They're quite niche, and they require large upfront costs because you have to change your entire X-ray room. So dual energy solutions to date have seen slow adoption because of motion artifacts, the higher radiation and the workflow issue, change in workflow, obviously, and expensive systems. Next slide. Now, to walk you through historically what happened with dual energy. Dual energy was invented, or kind of discovered rather, in the 1970s. In the 1990s, the most popular commercial dual energy solution was actually through Fuji. And what they did was they used something called a dual layer detector technology. So they took two CR plates and they put a copper mid filter in the middle. The idea was that you would use a conventional X-ray source, you would turn on the X-ray exposure, and the top layer would capture some of the low energy photons, and then the copper mid filter would filter out the stuff in the middle, and then the bottom layer would get high energy photons. By doing this, the top layer and the bottom layer had two spectrally different images, which would allow them to obtain dual energy subtraction. The idea was good in principle, but the implementation had some challenges. The biggest implementation issue, of course, is the copper mid filter. More than half the incident photons were lost in the copper mid filter, leading to a pretty poor dose efficiency. And in fact, this solution is no longer used today. They took it off the market. The dual energy image quality was a function of basically the copper mid filter. If you used a good thick mid filter, you would get a good dual energy image, but you would drive the dose to be very high. So it was not a good solution, but it was a solution, and lots of literature and clinical studies were done in the 90s that actually showed dual energy was excellent at picking up nodules. Next slide. In 2000s, GE introduced a new type of dual energy where instead of using a sandwich layer detector, they went and used a special X-ray source which allowed them to switch between a low energy and a high energy quite quickly, but they used a regular digital detector. In this particular case, there was some improvements because you got your low energy X-ray separate from the high energy, so you could optimize. The dose efficiency was definitely better than the 90s, but you still had to take two exposures, so it was not as low as that of a chest X-ray. You also needed to make sure the grid was always there, which increased the dose, especially to patients who may not have needed a grid. So higher radiation was an issue. The image quality was pretty good, except it was muddled with motion artifacts that we've seen previously. So people don't really like motion artifacts because it's a bit of an uncertainty in the image quality and image consistency. Next slide. And in 2010, bone suppression software started to become popular. Now, bone suppression software, I have to specify, is not really dual energy because it's not based on physics. It's based on morphology or anatomy, if you will. So the software recognizes what a bone looks like, the software recognizes what a nodule looks like, and then tries to perform bone separation. Doesn't really do differentiation as we've talked about from dual energy. The advantage of this software is that it used the same X-ray image as the chest image. So the dose efficiency was exactly the same as a chest X-ray. But the disadvantage of this is the bone suppression is actually not as good as dual energy. And in fact, in many studies, has been shown to be to perform worse than dual energy subtraction. It's also got very limited use cases, like just nodules and maybe lines and tubes. You can't really use it in every scenario. It's also got limited views. You can't really use it for laterals or obliques. It's really just PAAP. And you can't really distinguish if something is calcium or not. Next slide. Which brings us to the 2020s. And that's the triple layer detector technology. This is a detector that's actually being made by KA Imaging and is now available. And the idea behind this detector is it goes back to the beginning, back to the sandwich layer ideas, but instead of using a mid filter, it replaces the mid filter with the middle sensor layer. So there's no mid filter, you've got 3 sensing layers. The advantage of using 3 sensing layers is that you capture more photons than any X-ray detector out there. So your dose efficiency is actually excellent. It's actually better than standard chest X-ray because your DQEs on this detector are better than any other X-ray detector out there. And on the dual energy image quality side, you also get good dual energy images because you can do the separation between the top and the bottom layers. The other advantage is because all the 3 images are acquired in a single snapshot, there's no motion artifact. So the image quality is superb, and we'll see some of that. Next slide. Now, how do the 3 layers work? So here you can see the X-ray source in the red-orange dot right there. And in the top layer, the original beam spectra is seen. In the second layer, like some of it is filtered, the stuff that was filtered in the top layer, and in the last layer is after 2 filtrations, right? So a single 120 kV exposure generates 3 distinct spectral images. By the way, you can use a different energy. It doesn't have to be 120 kV. It's just 120 kV is common for chest. Thickness for each layer can be optimized for best spectral separation. The signals from all the 3 layers are added to get the best DQE in the class, and signals from layer 1 and layer 3 are subtracted, so you get your dual energy, and simultaneous acquisition of the 3 images gives you no motion artifact whatsoever. Next slide. Here's an example of the DQE that was measured on these devices. The multiple sensor layers for the triple layer detector enable up to a 30% less radiation to the patient compared to a standard digital X-ray. That's the DQE curve across a variety of frequencies all the way up to 3 line pairs per millimeter. So even small structures can have good fidelity. The advantage, of course, is you're using the same source, the same technique, and the same dose as a standard chest X-ray. So you've not changed anything, but you've gained all the advantages of dual energy because you get your X-ray image plus you get the dual energy images in essence for free. And these radiation levels are, of course, 50 times less than CT, with outcomes becoming quite comparable in many situations. And that's where the exciting part sits. Next slide. So here's an example. You've got your DR room, you've got your mobile X-ray. Simply by changing the X-ray detector, you don't have to swap out the whole equipment, just the X-ray detector, you can get diagnostic accuracy that starts to approach that of a CT scanner in many modalities. 3 images from 1 chest X-ray exposure maintain the same clinical technique and dose, and you can see some of these images. Jay's going to go through them in a lot more detail. Next slide. So here's a comparison between the single exposure dual energy versus bone suppression versus dual exposure dual energy and a regular chest X-ray. As I noted previously, the clinical use cases for single exposure dual energy are actually more than chest X-ray because it enables more applications than chest X-ray. Bone suppression is limited to nodules, lines, and tubes. That's about it. Dual energy, the older generation dual energy is pretty good. It's better than bone suppression, but it still has less use cases, primarily because of the higher radiation. The radiation levels for single exposure, of course, are the same as chest X-ray. The grid can be used as per clinical technique. That's a disadvantage for traditional dual energy. They always need a grid. It's got better sensitivity than a chest X-ray, obviously the ability to tell calcium from soft tissue. The other advantage that's really interesting is you can use it for any view, AP, PA, lateral, oblique, just like you would with a regular chest X-ray. This cannot be done for bone suppression or for traditional dual energy because of a variety of reasons. And of course, this device, the single exposure dual energy, because it's a detector solution, it's portable and mobile, and it's got no motion artifacts. Next slide. So just to give you an idea of motion artifacts, these are 3 solutions from other vendors who have been selling dual energy for quite some time in the market. In each of these bone images, you can see motion artifact quite clearly. Whereas if you look at the solution on the right, that's actually single exposure dual energy, you'll notice what's striking is that there is no motion artifact. And again, not a surprise because the 3 images are acquired simultaneously. Next slide. So what do these situations have in common? And this is what we mean by dual energy being a game changer. In one case, you've got trauma at the roadside, you've got a long-term care patient, an emergency ward, and an ICU. All of these 3 situations, next slide, require mobile diagnostics. That's essential to save lives, and this is where dual energy portable X-ray can be a real game changer. Next slide.
Okay.
I'll pass it off to Jay now.
So my name is Jay Potipcoe. I'm the clinical application specialist for KA imaging, and my background's in CT and in general radiography. So it's a pleasure to talk to you about something that's quite interesting on my end here. So we're asking, what clinical and economic benefits can dual energy X-ray provide to imaging departments? And that's what I'm going to go through now. So it has multiple benefits for some pretty diverse stakeholders. So if we look at hospital administrators, it has an excellent overall benefit to the operations efficiency and effectiveness of the care provided by the hospital. In terms of the radiologist, we have more accurate, more confident diagnoses and one-click access to supplemental DE images, one soft tissue and one bone image. For the technologist, it leverages all of the existing workflows, techniques, and clinical parameters that they're used to, and also a particular interest. It's portable and produces excellent quality portable images. That's one area that it can be very challenging to get a high quality image, and the way that reveal or that single exposure dual energy works, it really opens up the parameters in terms of what can be done with portable imaging, and makes it a lot easier to get a high quality image. And of course, for the patient, they benefit at the end. Early diagnosis equal more treatment time at no extra dose. Okay, next slide. So here we have some cases that we'll go through to just kind of highlight the ways in which single exposure DE can kind of change the game, so to speak. So this case here, it was initially read as normal. Without the DE images at first, the radiologist was shown a conventional DR X-ray and read it as normal. But there's actually an apical lesion that's hiding under some bone there in the upper lung on the patient's right side. So when given the DE images, the radiologist actually noticed that there's a prominent lesion there that needs to be obviously looked at. So without the dual energy images, the patient would have gone home thinking they were fine and lost out on some proactive treatment time. So next case. This case here just goes to show kind of the power of the differentiation in single exposure DE. So there was a granuloma here that was believed to be calcified when the radiologist was just given the DR image. But when he or she was given the 2 supplemental dual energy images, it was said with full confidence to be a calcified granuloma, being that it is seen in the bone image only and completely absent in the soft tissue image. There is, however, kind of a lot more going on with this story, and there's a mass behind the heart that's not seen in this PA image. So we've said again, existing dual energy cannot perform lateral images for a variety of reasons. Single exposure dual energy is fully capable of producing these lateral images that in this case will really have a direct tangible benefit on the patient. So we'll go to the next slide here. So this is a lateral of the same patient. But yet again, even though we're in the lateral configuration, it's experiencing superimposition. So the lesion is overlapped by a calcified joint there. But given the availability of the 2DE images, the soft tissue lesion appears without superimposition in its respective image, and then the calcified joint appears on its own in its respective image. So it gives the power to provide excellent information about the composition of any pathology that's seen. So given the fact that it can do not only dual energy images, but remove the superimposition that just sometimes happens, it greatly enhances the reading capabilities and has a direct benefit to the patient, the radiologist, and the technologist. Next slide, please. So here we see how dual energy can kind of increase confidence for focal opacities, pneumonias. The first image was read as normal, but as luck would have it, there's a portacath outlet there for venous access, and right behind it there's a focal opacity that's positive for pneumonia. So again, given only the DR image, the radiologists read the case as normal, but when given the soft tissue image, they saw there was a soft tissue lesion hiding right behind that outlet, which was subsequently confirmed on CT. So again, earlier diagnosis, better outcome for the patient, and all-around benefits for every stakeholder. Next slide. This goes to show how the two supplementary images can boost confidence from, say, in this case, 20% to 100%. So this is a 74-year-old male patient with leukemia, where the radiologist, he or she read it as positive for fungal pneumonia, but with very low confidence. They placed it at 1 out of 5. But when given the subsequent soft tissue image, they placed their confidence reading at 100%, and it could be said to definitively be a consolidation. So again, not only does it clarify what's going on, but it brought out all of these other pneumonias that were missed bilaterally on both sides, and confirmed this diagnosis in CT. So again, we see early diagnosis, more confident diagnosis, and highlighting these, somewhat incidental findings that were lurking there, but obviously not seen. So we'll go to the next slide. This just kind of goes to show a really interesting point, that cardiac stents and calcifications can be seen in a lateral single exposure dual energy image, and you can actually see the angiographic stent there put in during a vascular procedure in the interventional suite. So combined with the high DQE, with the ability to differentiate and separate the soft tissue image out, really gives quite a remarkable lateral view at patients' stents and calcifications. So we'll go to the next slide. This kind of, again, goes to show the benefits with respect to coronary vessels and the calcifications thereof. Again, we see the clearly defined calcifications in the heart, in the coronary vessels, just hiding behind, not hiding behind, but located behind the portacath line. And we can also very easily see some sternal ties there, and the lateral sternum very nicely differentiated in this slide. So this is something that you would never see in another in another DR image, and you'd certainly not see it in any other dual energy image, because as we've said, they can't be produced in a lateral configuration. We'll go to the next slide. Now here we have a pneumothorax, and it just goes to, again, show how a certain pathology can just kind of leap out at you with the proper processing and the availability of the two supplemental DE images. Pneumothorax is something that's quite common. It's a pathology that every ER department sees a lot of. And here we have some pictures of a 26-year-old male presented to the ER with upper chest pain. The DR image showed, kind of, it shows the pneumothorax, but again, in a busy situation, or if there was perhaps not a radiologist available late at night or in a more rural setting, this it could go missed. And I think the soft tissue image here just really highlights, without a doubt, a lot better than the DR, that there is something going on here. And you can clearly see with the bone removed, the absence of lung markings in the way. So when you take that superimposition out, it kind of allows any pathology with the lungs to just jump out at you, and allows you to focus on just the lungs. So here we see, yet again, with another very specific pathology, how it is a great benefit to not only the radiologist, but in this case, the reading physician when there might not be a radiologist present, and of course the patient who can go get this taken care of before it gets out of control and really progresses. We'll go to the next slide. We'll talk about some health economics here in terms of single exposure DE. So as a case study here, we have pneumonia. It's a very significant pathology. It's something that results in over 1 million admissions to hospitals each year in the US, and accounts for over 60,000 deaths at a rate of about 6% mortality for these admitted patients. And for inpatients, it's really problematic, especially for folks who aren't ambulatory. They're lying down supine, and there's not a lot of movement. Things get stagnant and fluid builds up in the lungs. So pneumonia really is a problem for inpatients, and for DE to be able to enhance diagnosis really has a direct benefit to them. We see here it's almost $10 billion in annual cost to US healthcare per year, and has a fairly high readmission rate, approaching 8.8% within 1 month. So quite a few patients will be back. So that's something, if we can address it early, treat it early, that has a direct downstream benefit for the healthcare system as a whole. 37% of these cases are self-insured, and in many cases they don't end up paying for the treatment, so the hospital ends up running at a loss for that case. So if we can resolve these issues as they occur and create less of a readmission flow, it'll have again a direct benefit for the self-insured folks who compose a lot of these revisits to the ER for pneumonia. Next slide, please. So here we see, pneumonia, it's quite remarkable. It's misdiagnosed in 1 in 3 patients. So we saw in the previous slide the cost ramifications that this had for the healthcare institution as a whole, and the healthcare system. The sensitivity for pneumonia in conventional X-rays is quite poor compared to single exposure DE. So this can be used, single exposure DE can be used for great benefit, not only for pneumonia, but for other lung pathologies. When we compare the sensitivity here in chest X-ray, conventional chest X-ray versus single exposure DE, we see in the case of emphysema, 45% with conventional X-ray jumps up to 75% with single exposure DE. That's quite a remarkable increase. It's a 66% improvement from that 45%. So something very significant there. Consolidation, 41% to 61%. That's an increase of half. And kind of most remarkably, at lung atelectases, we see an increase many times over. It's over 3 times an increase. So really just showing there in the data how much of an improvement implementing just a single one single panel can do in terms of having an overarching benefit for the patient, again, and all of the stakeholders concerned. And this most readily, I think, comes out in the emergency department, where we can make the greatest difference with pneumonia, as well as in some of the longer term medicine wards in the ICU. So I'll go on to the next slide. This is a healthcare and economics case that pertains to nodules. You know, it's a scary topic in that it's a particularly sinister disease, of course, and can get out of control very quickly if not found early. So this is a pathology that we want to, of course, find early, and that finding early and diagnosing early and subsequently treating early and correctly can have just a great benefit and absolutely save lives. So late detection of solitary pulmonary nodules has very negative ramifications. And simple math shows that with a prevalence of 0.15% existence in just the general US population, combined with 150 million chest x-rays performed annually in the US, that gives us nearly a 250,000 cases of solitary pulmonary nodules that could have been found just incidentally by implementing single exposure dual energy panels. When we kind of extrapolate that and look at some of the costs and effects down the line, data suggests that statistically about 1.6 out of every 1,000 cases of missed nodules will result in legal action, resulting in $100 million annually of lawsuit payouts for just missed nodules alone. So $300,000 per claim. And being that dual energy X-ray has a 33% higher sensitivity, we really see how that could save not only quite a few lives, but millions of dollars as well. With this 33% increase, an average hospital taking about 120 chest x-rays a day would, just by virtue of using dual energy, find an extra 12 cases of nodules every year compared to regular x-ray. So at a conservative estimate of $10,000 per patient, that alone provides $120,000 per year in extra billing revenue for the hospital. So again, earlier and easier detection results in better patient outcome, more downstream revenue, and greatly enhanced risk avoidance on behalf of the reading physician and the institution. Next slide here. So again, with the increase in sensitivity of 33%, it has huge benefit to the outcomes for multiple stakeholders. Earlier diagnosis and incidental diagnoses greatly improve the patient treatment effectiveness, and of course, by virtue of those two, the patient outcome and prognosis. So through implementing single exposure DE, not only acute care settings, but in outpatient care settings, you're going to boost and augment early detection of solitary pulmonary nodules and save lives. So that's kind of a direct benefit in how it can benefit incidental findings of just non-acute patients walking into outpatient clinics. And our third case, as we've seen before, small volume pneumothorax, something that happens quite a lot in the ER at night. The average cost of treatment is $25,000 per case on average, and of course that goes up if the case gets complicated. They're challenging to identify, and there's 50,000 of them induced by medical error every year. And this doesn't even include spontaneous and traumatic pneumothoraces, which can cause death if not found and treated early. Missed diagnoses can for pneumothoraces, develop inattention pneumothoraces, which are life-threatening and have a mortality rate of up to 9 in 10 ICU patients. So quite scary and something you want to jump on top of. Dual energy X-ray boosts detection sensitivity and specificity significantly. So we're going to, again, have greater avoidance of malpractice, fewer suits, and better outcomes for patients who can get treated conservatively, whether it be through oxygen and maybe avoid having something more drastic like having a chest tube put in. Next slide. Now, again, it just kind of breaks down how different levels of experience reap the benefits of dual energy in terms of their pneumothoraces diagnosis here. And it's most pronounced with interns who are still learning to gain the expertise of a fully qualified radiologist. And we see quite a great leap there at around 33%. So again, benefits for all, but for the most impactful change was seen for the intern level. So to summarize here, 5 pathologies with high economic impact. Dual energy provides an increase in sensitivity of 33% for nodules. Cardiac disease is a huge factor. It's the #1 killer in the developed world, and dual energy can greatly increase the diagnosis of calcified coronary vasculature, and can even be scored, which we'll touch on briefly here. For pneumonia, it's misdiagnosed in 1/3 of cases, so dual energy is at a huge benefit here with a sensitivity increase in 50%, and over 3 times for atelectasis. Pneumothoraces, again, great benefit here, up to 30% higher detection rates for small volume challenging pneumothoraces, even by residents and interns who aren't at the expert level. And finally, tuberculosis, something that's a huge factor across the globe, and results in 1.5 million deaths annually. So given that single exposure DE can result in a 30% increase, the benefit here becomes quite powerful in that you really see how many lives could potentially be saved by implementing DE in areas of the world where there's a high TB prevalence rate. This table here summarizes the economic impact of adopting dual energy X-ray in some of the projected additional cases. I'd like to highlight that these aren't the total number of cases. These are just incidental extra cases that will be found every year. So 12 more cases for the average institution annually of pulmonary nodules. Again, estimated conservatively at $10,000 a case per treatment cost, results in $120,000 of additional billings. And you can see for each of these 4 pathologies how, again, it benefits the patients, the institution, and the reading radiologist in terms of risk avoidance and malpractice costs. So looking to the future, artificial intelligence. AI is predicated, of course, on one thing, it's data. The more data available, the greater the learning power and the quicker the learning of the AI program. So rather than compete with AI, we have found that they can be paired quite nicely to actually complement each other. As of this point, dual energy has been paired as a complement application to artificial intelligence in a separate application, but moving forward, it's going to be integrated into the same program to work as one. Next slide. When compared with a commercial artificial intelligence product that reads DR conventional X-rays, we see how lacking it is compared with single exposure dual energy. this is an example of an AI program, a commercial AI algorithm that was applied to a DR image to read it, and it's completely missed nodules adjacent to the mediastinum that we'll see in the next slide. There's also a pneumonia that was completely missed. But when we look at the dual energy images, it would not take a machine to see this. And in fact, it doesn't take a trained expert to see that there's quite a prominent pneumonia there, as well as some mediastinal calcifications. So given that the artificial intelligence program missed this in the reading of the conventional X-ray, it goes to show that compared with single exposure DE, still has a long way to go and is not is no comparison to DE. And just looking towards the future, a lot of patients can be spared the extra radiation of a CT calcium scoring test. As data, some preliminary testing shows that there's clinical correlation for calcium scoring on single exposure dual energy images that's clinically accurate as compared with calcium CT scoring done with the Agatston scale. So if you can spare patients a more lengthy CT exam, and of course save them a radiation that could be over 100 times what they would get with the X-ray, again, great benefit to the patient. Next slide. So to summarize, we have, again, single exposure dual energy benefiting multiple stakeholders, a diverse group of stakeholders, better, more confident, quicker diagnoses for reading radiologists and reading physicians, clinical benefits overarching in terms of institutional effectiveness, boosted, and risk avoidance. And with the patient, there's no additional procedure, dose, same as a chest X-ray. And for the end user, the technologist, it enables them to leverage existing X-ray equipment and clinical techniques that they're familiar with and they've used 1,000 times before. So that's a bit of a brief overview of the clinical application side of single exposure dual energy. So at this point, we'd like to perhaps open it up to some questions.
Thank you both so much for a great presentation. We do have some questions that have come in, and as a reminder to the audience, you can ask a question using the questions feature in the webinar dashboard. Our first question is, how is single exposure dual X-ray different than DR X-ray with bone suppression software?
Yeah, absolutely. That's a great question. So bone suppression software is it's a software solution. It's based on recognizing what ribs and nodules look like. And it shares some things in common with dual energy, but its biggest weakness is that it can only really be used for very specific use cases like nodules and lines. And it cannot be used for lateral or oblique type images. Whereas for single exposure dual energy, you can actually differentiate bone and soft tissue. You can use it for coronary calcium. You could use it for nodules, pneumonia, COVID pneumonia, pneumothorax, pneumoconiosis. The application pool is significantly larger. In fact, single exposure dual energy does everything that chest X-ray does plus more. And plus, single exposure dual energy can also be used for laterals and obliques, which is quite useful. And the other piece I'll point out also is when you use this type of software in a portable setting where the patient is not placed ideally, which is often the case in portable, a software-based solution will often struggle to come up with a good outcome. Whereas for dual energy, because it leverages the physics, it results in a much better outcome more frequently.
Great. All right. Our next question is, Can you explain in more detail how the three-layer system works? What computational techniques are used to layer the results in two images?
Absolutely. So the way the system works is you've got 3 layers and you've got a 120 kV beam spectrum that's incident. That's been hardened by the patient, and then it passes through the 3 layers, with each of the layers taking a sample of that beam spectrum. So the lower energy photons get absorbed in the top layer, the middle energy in the middle layer, and the high energy in the bottom layer, roughly speaking. It's statistical, but roughly speaking, that's what happens. And then a simple algorithmic weighted logarithmic subtraction is employed, along with some corrections that are required to account for like the position of the detector and whatnot. But that's basically it. And you get an image, and you get your dual energy data that just comes right out. And at the same time, you can simply add the signals from each of the 3 layers, and you get your conventional X-ray image. So you get both the conventional X-ray image plus 2 supplementary dual energy images in a single exposure at the same dose, the same technique, and using the same X-ray source as a chest X-ray.
Perfect. Our next question is, are dual energy radiography and phase contrast X-ray imaging essentially the same thing?
No, they're not. Phase contrast X-ray imaging tries to look at the refraction in the X-ray. So when an X-ray passes through an object, it's going to deviate slightly from its path because of the interaction in that material. Phase contrast X-ray has not really been clinically demonstrated on full-size patients. I think it's still in clinical study for breast cancer. It may not work as well for chest X-ray because the patient volumes are too large. Dual energy, on the other hand, is very different. It's been around for 40 years, and it's looking at, as I mentioned earlier, the attenuation of different energy X-rays in different materials. So dual energy is a material separation technique. Phase contrast is a technique that can highlight soft tissue, but they are very different techniques.
Perfect. Thank you so much, Karim and Jay, for your time today and for a great presentation. I'd like to encourage everyone to visit today's sponsor to learn more about the services they provide to our industry. Please visit kaimaging.com. As a reminder to our audience, you can obtain your continuing education certificate by completing the post-webinar survey. This survey will be emailed to you 1 hour after we are completed today. You must complete the survey to receive your 1 continuing education credit, and you will be able to download your certificate as soon as the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. ICE Magazine is proud to bring our new monthly webinar series to the imaging industry. Thank you for being part of the ICE community. For more information about our upcoming webinars, please visit icewebinars.live. Thank you all and have a great day.
Thank you.
Thanks.